topic today is patient abuse. My name is Adam Vaughn, and as the program director here at the nursing facility, I feel like this is the main issue that we need to discuss as a staff, and it is a problem that is leaking down to the lowest level. I do not like it. I don't think it's appropriate. We're beginning to get in newspaper headlines, and I would like to put a stop to it. So please wait till your questions after the presentation, and we will discuss it at that time. Patient abuse is the mistreatment or neglect of individuals who are under the care of a healthcare organization. Abuse is not limited to an institutional setting such as ours, and may occur in an individual's home as well as in an institution. Abuse can take many forms: physical, psychological, medical, and financial. To compound the issue, abuse is not always easy to identify because injuries often can be attributed to other causes, especially in elderly patients, our primary focus, with their advanced age and failing health. In the hospital setting, patients are not generally as dependent on the facility operator in the same manner as a resident in a nursing facility such as ours. Persons are usually just hospitalized for only brief periods, whereas in nursing facilities, residents may be dependent on the facility operator for years, as in our case a lot of residents are. Thus, the potential for long-term abuse and neglect is far greater for us than it is for hospital patients. It's hard to determine when someone has actually been abused, and the courts are still deciding in different cases what abuse has been done and if it is abuse at all. In the past, abuse of nursing facility residents had given emphasis to strengthening the resident rights of people, and so Congress created the Omnibus Budget Reconciliation Act of 1989. This act provides that a resident has the right to be free from verbal, sexual, physical, or mental abuse, corporal punishment, and involuntary seclusion. And although residents' rights have been significantly strengthened from this act, resident abuse is often in the newspaper, and such is the case in our facility. These signs of abuse have included physician's orders for restraints, time-limited orders, number of patients who are physically restrained, the type of restraints being used, the restraints not being applied correctly, the apparent physical and mental condition of the restrained patients, whether restraints are released as required by law, and whether exercise is provided for the patient, whether the staff responds to requests for water, assistance to the bathroom, and so forth from a patient who is restrained, and the interval of time between the request and the response. It includes how often restrained patients are observed by the staff, the effect of restraints on patients, and signs of overmedication, the frequency of overmedication, and signs of mental and physical abuse of patients. I would like to provide an example of the case of State versus Cunningham, in that the owner and administrator of a residential care facility that housed mentally retarded and elderly residents had come under inspection from the Iowa Department of Inspections and Appeals as they conducted a routine inspection of the facility. Upon looking at it, the inspection team had found that Cunningham, the owner, had refused to provide or exercise adequate supervision to remedy or attempt to remedy dangerous situations, which included residents being exposed to physical dangers and unhealthy and unsanitary physical conditions, and they were grossly deprived of much-needed medical care and personal attention. The conditions at the facility were likely and did cause injury to the physical and mental well-being of the facility's residents. Based on these findings, the defendant, Cunningham, was found guilty on counts of neglect. Part of this included fire hazards and circumstances that impeded safety from fire. There were cigarette stubs found in a cardboard box and burn holes found in patient clothing on furniture and in non-smoking areas. There was exposed electrical wiring found, along with a bent and rusted fire door that could not close or latch. The facility was not properly maintained and demonstrated many health and safety violations, including broken glass in a patient's room, excessive hot water in faucets, dried feces on public bathroom walls and grab bars, no soap in the kitchen, insufficient towels and linens, dead and live cockroaches and worms in the food preparation area, and debris, bugs, and grease throughout the facility. Dietary facilities were unsanitary and inadequate to meet the dietary needs of the residents. In one case, an ordered no concentrated sweets diet for a diabetic patient was not followed, subjecting the patient to life-threatening blood sugar levels. There were also inadequate staffing patterns and supervision in the facility. No funds were spent on employee training, and the defendant did not spend the minimum amount of time at the facility as required by administrative standards. There were also improper dosages of medications where they were administered to the resident. For example, physicians had distributed an ongoing overdose of heart medication to one resident while failing to administer medication altogether to another. Another example of abuse has been forced administration of medication. Now, in our facility, there has been a lot of people complaining that some of our nursing staff are holding their patients' chin down. This is not authorized without an emergency notification to a head nurse and physician, and I would just like to point this out. We do not tolerate forced administration of medications. Now, if you feel the need that you have to give someone medication and they refuse to do it, there are a lot of other ways that we can go about it. I would like to go over some improvement strategies that I believe we can all work on together to come to a solution on reducing and eliminating patient abuse. One is to increase patient interaction. And what I mean by this is for all of us to work more closely with patients in providing for their needs by not particularly becoming their friend, but becoming more friendly with them. And that could include nursing staff going into each room and discussing the day with the patient, finding out how they're doing, finding out if there's anything going on with their personal life, with their private life, if they're getting all the attention that they need from their personal life, because a lot of times some of our patients don't have family members come visit them every day and they get lonely. And I feel like that if we as a organization come together and truly work on getting closer with our patients, that they won't have a desire to say abuse or I'm being threatened in any way, because we all have an increased understanding of we like you, you like me. Another thing I think we should do more closely is to review patient records thoroughly. We should understand if this patient may have a problem with having medication forced down their throat, because we'll be able to see and document that yes, they have told us they don't like taking medicine, they don't want this, they don't want that. And so if we have that in documentation, when it's time for those patients to be medicated in whatever form they do not like, we have the appropriate staff available to reduce and minimize the risk of so-called abuse and allow that patient to take her medication as medically necessary. Another one of the things I'd like to start is having quality control meetings at the lowest level. And what I mean is by lowest level, that could include your shift, your wing, any type of level that we have broken ourselves up into at this facility. We each need to sit down before, during, after the day, and say, okay, what can I do better today? What did I do wrong today? What are the things that could make all of us, what did I do that other people can say, oh yeah, I'd like to do that too, because it's the best way we can do it. Especially when it comes to nurses switching shifts and what's the best way to take care of this patient on a 24-hour basis. A lot of the nurses who come in may not know what happened on the prior shift and may not necessarily read the documentation for whatever reason, and so they don't know that such and such nurse has established this with this patient. And so if we sit down and say, hey, this is how we're going to better facilitate our changing shifts or changing patterns and how we control our medications with this patient, I really believe that we can improve on eliminating patient abuse. One other thing that I would like to express is an increase in family participation. And that would include that when you do see family members coming in and seeing patients, I would, stress to you to better consume your time with allowing that patient to know who you are and that we are there to serve everyone and their best needs. And so they can also help the family member. The family member can also help the patient into taking their medication, letting them understand that that medication needs to be taken so that there is no abuse. If we have no further improvements to talk about, I would like to address any questions that might be taken from the floor. So please, at this time, ask me any questions.